Hi guys, welcome back. The next topic we're studying is metabolic syndrome. The alternative term used for it is syndrome X, and I'll be comparing syndrome X with syndrome Z. And towards the end, I'll talk about another term called as coronary syndrome X. So let's dive into the data here and let's study these technical terms. The first image that I'm showing you is from urban India. You see the centripetal obesity component is dramatically increasing in our country because people don't want to cook. Actually, there are so many apps available, right? I mean, people would be ordering food from outside, and the biggest problem with restaurant food is trans fats. After trans fats, because they're not going to change the cooking oil, so trans fat intake in a normal person should be 0%. But if this person is going to regularly eat trans fat, saturated fat, and above that carbohydrates, then centripetal obesity would come in, and that is one of the features that will be important for diagnosis of what we are talking about as metabolic syndrome. If you look at the inferior image, I have here shown a sumo wrestler. A sumo wrestler will be obviously very bulky, and he might be also eating almost 10,000 calories per day. But you will notice the sumo wrestlers hardly or very rarely develop heart disease, or the incidence of heart disease would be equal to what would be present in ordinary Japanese population. Well, the difference is that a sumo wrestler will be having subcutaneous obesity. The fat is just below the skin, and anyway these guys do workout also now, but every day he will have to exercise a lot apart from obviously piling on fat and trying to increase his body weight. But sumo wrestlers tend to have relatively lesser incidence of heart disease. Another factor that has been incriminated why Japanese tend to have lesser incidence of coronary artery diseases because of intake of fish, because fish would have fish oil, and that has been shown to actually improve the lipid profile of an individual. Now, from the Indian perspective, because the incidence of metabolic syndrome has dramatically increased, so lots of time questions on this topic are asked. So the first and the foremost diagnostic feature of metabolic syndrome, I'm going to teach you 5 out of 5, 3 should be positive. I repeat again, I'm going to teach you 5 features out of 5, at least 3 should be positive for diagnosis of metabolic syndrome, the alternative name for which is syndrome X. The first and the foremost, though I've already highlighted, let's measure the centripetal obesity by measuring the abdominal girth of this individual. I am going to measure the abdominal circumference. If you measure abdominal circumference in a male patient and it is found to be more than 102 centimeter, in a female patient, if it is found to be more than 80 centimeter, it is suggestive of centripetal obesity. Though obviously this is for Western population, because you would have noticed that Americans or European people are much more bigger and I would say heftier than us. So from a Indian male's perspective, if he says abdominal circumference more than 90, and from an Indian female perspective, if he says abdominal circumference more than 80 centimeter, it is diagnostic of centripetal obesity. And the bad news is along with this would also come insulin resistance. When the centripetal obesity comes, concomitant to that, these patients will develop a impaired glucose tolerance slash insulin resistance. If you're gonna check the fasting blood sugar of this patient, it will be anything between 100 to 125 milligram percent. The 2-hour values would be oscillating anywhere between 140 to 199. So there can be two possibilities. Either he will be having this report, that is impaired glucose tolerance documented, or the patient could be already on oral hypoglycemic drugs. Like this guy is already on oral hypoglycemic drugs because his HbA1c was more than 6.5%, and the routine interventions in the form of dietary modification and exercise was not working. The third biggest problem with these patients would be that because the body weight is more, the centripetal obesity component, the visceral obesity component contributes to increase in peripheral resistance, and this increase in peripheral resistance will upgrade the blood pressure of this guy. So the next feature that you will encounter will be hypertension. Now, I have explained to you that the cutoff for hypertension in Harrison 20th is 140 by 90. But for this particular patient, I want you to remember a cutoff of 130 by 85 millimeter of mercury. I repeat the fact once again, the traditional value I taught you was 140 by 90. But this time I'm mentioning 130 by 85 millimeter of mercury. We are having a deliberately low threshold of blood pressure here because cardiovascular mortality is anyway going to be increased in these patients. These patients with centripetal obesity will have higher incidence of coronary artery disease. Now, once I know that this person is on hypertension, there is also possibility that he might be on hypertension medication also. So I want you to remember that in the diagnostic criteria, either of the two can be present. Either is a newly diagnosed case of hypertension or is already on hypertension medication. Similarly, for point number 2, already a diabetic on oral hypoglycemic drugs or a newly diagnosed case with impaired glucose tolerance. The fourth point I wanted to remember in the discussion would be a deranged lipid profile. You see, what is elevated in the blood of this patient is predominantly triglycerides. In the diagnostic criteria of metabolic syndrome, it is not increased cholesterol, it is not increased LDL, It is increased triglycerides. It is hypertriglyceridemia or values more than 150 milligram percent, which is definitely of concern in conjunction with a low value of HDL. Now the good cholesterol values would obviously be depend on the gender, so it could be written 40 or 50 milligram percent dependent on the gender per se. But I want you to understand that out of the 5 features that I've just explained to you, the features are weight is more, sugar is more, blood pressure is more, triglycerides are more, and HDL is lesser. Out of the 5 features that we have just discussed, if 3 out of these 5 features are present, we can say that our person is or patient is suffering from syndrome X slash metabolic syndrome. Both imply the same, because half the time you will notice that it is terminology that matters, and you will realize the significance of why I'm writing this once again in just about 2 minutes from now. What he asked in the exam was deliberately syndrome Z, because he knew that you have already studied about syndrome X per se. So what is syndrome Z, guys? So you need to remember this would be a combo of obstructive sleep apnea. I've just highlighted that data. It is combination of obstructive sleep apnea with syndrome X. So obviously 5 out of 3 features would be present in whatever we have discussed. The additional thing would be that this guy says, sir, I never wake up fresh. Like when I wake up in the morning, all I want is when would I sleep again? He is feeling sleepy because every time when he was sleeping, he was snoring very loudly. Obstructive sleep apnea is a separate discussion that I have taken in the respiratory section. And the definition of apneic episode in this case would be a duration more than 10 seconds, which will be associated with desaturation. The SpO2 of this person will begin to fall. If you document more than 5 episodes, actually it could be up to 15, even more, but if you document at least 5 episodes per hour of apneic episodes in an individual, which is documented by polysomnography, then this person will not only require a non-invasive ventilation and a tight fitting face mask when he's sleeping, so that I can tide over the hypoxic drive to the brain, but at the same time there would be concomitant findings of syndrome X as well. So mainly the question was revolving around what is the special add-on feature for syndrome Z. The answer is obstructive sleep apnea. Now comes the main reason why I've discussed this topic. Lots of time he will write the word coronary syndrome X, and you can very well understand that when there is a pressure cooker situation in the exam, there is a possibility that a person can miss the word coronary and start thinking this to be syndrome X. Well, what do you mean by the word coronary syndrome X is that it is no problem with the epicardial coronary artery, the left anterior descending, left circumflex, or the main left coronary artery, everything's perfect. It is the ultra small branches of the epicardial coronary arteries which are affected in this condition. This particular patient is having a perforator narrowing, so the smaller branches of the epicardial coronary artery are basically responsible for coronary ischemia of this person. Now let us see how he will present. The symptoms of these patients will be identical to that of chronic stable angina. The chest pain would be coming on exercise or emotion or after intake of food, or a combination of the 2 or 3 of the things that I said. So you will obviously subject this patient to a treadmill test. It's not going to be a one-off episode. He says, sir, every time I walk fast, every time I have a fight with my family members, there is development of these chest pain episodes. Hence, I have decided to do a treadmill test in this individual, and the treadmill test actually showed also evidence of ST depression, as I've highlighted, ST depression of more than 1 millimeter and at least persisting for 80 milliseconds in 2 of the limb leads per se, suggests presence of coronary involvement. In this guy, I have now decided to go for coronary angiography so that I can see which blood vessels are blocked, how much percentage of blockage is there, and I also want to identify whether it is single vessel disease, double vessel disease, or triple vessel disease. Because it is triple vessel, we will preferably do coronary artery bypass grafting in this patient. When the report of angiography came, it was surprising to me, because angiography report is normal though treadmill test is positive and symptoms of chronic stable angina are present. That is when I'll diagnose this condition, coronary syndrome X. Guys, this condition is also referred to as microvascular angina. Now, had I introduced or had the examiner introduced this term, you will never get it wrong, because the moment he says microvascular angina, you know the fact that it is perforator involvement. Now, the moment the examiner will say microvascular angina, you will be immediately able to identify that this is a case of perforator narrowing in a person. So that is why the term coronary syndrome X has been highlighted in this case. And now comes the treatment. So I will not be recommending any stenting or coronary artery bypass grafting for this patient. I repeat the fact once again, there is no advantage of doing stenting in this case, because anyway the perforators, the distal blood vessels, are narrowed. For management of this person, I will be putting this person on long acting nitrate, that is isosorbate mononitrate with aspirin 75 milligram for the rest of his life. The combination of the two will definitely prolong the life of this guy. But from the exam perspective, the main reason why we have discussed this is that we should be clear regarding coronary syndrome X versus what I just explained, that is syndrome X versus a syndrome Z. So if you get the terminologies right for this topic, I would think that you would be definitely be able to get these questions right, and your strike rate would be relatively much better as compared to your rivals. Thank you so much for your patience and hearing me out, and I am very sure that as you will keep on learning new facts and keep on hammering these, drilling these facts into your brain. And anyway, as I highlight, I'll say that again, doctors are supposed to have a photographic memory. So when you listen to this data, this entire data should be imprinted in your brain in one or two reads itself. And try to do questions of the same topic on the same day, guys, because that is when you will try to evaluate yourself. And if you do not get them correct, don't fret about it, just read the explanation, because lots of time in MCQs also extra information is given. So if you make a combination of this, the theory and the MCQ part, gradually your mental strength will increase, and then you will realize that your performance when it comes to the final crunch time will definitely be better over your rivals. Thanks.